institution of breast MRI. So because this is very important for the new technique to be incorporated to the clinical practice, we need to think what's missing, what's the limitation of the current modality. So this is the limitation of breast MRI. So for the breast MRI diagnostic, we always use contrast agent gadolinium, okay? So with that, we can detect the lesion very easily, character lesion very easily, but on the other hand, we have many cases for false negatives, okay? So with contrast agent, we have many tiny spots appearing at the same time, which is very often challenging, whether they are the lesions or normal background parenchyma tissues. So we face many cases for false negatives. And there are overlaps between benign and malignant breast lesions. And as I've explained already, there are many incidental MRC lesions, etc. So in general, MRI exam, it takes a long time and it's expensive, and the patients have limited access compared to other modalities, and patients might have discomfort as well. So in breast MRI, in the current setting, we have the contrast agent. And there are many cutting-edge techniques as well from the contrast agent. One of that is abbreviated breast MRI. So this abbreviated breast MRI can address all these limitations. So let me show the next slide. Okay, so here is a breast cancer patient. So this is a mammogram. So can you diagnose this on a mammogram? If you can find a lesion, please raise your hand. For me, it's almost impossible because this patient has a high breast density. So these are all white signals on the mammogram shows, completely normal, but there might be the lesion somewhere. It's impossible for many cases to differentiate the lesion from the normal tissue. On the other hand, this is an MR image of abbreviated breast MRI with GAT. So with this MIP image, we can detect the lesion. With this image, we cannot differentiate, of course, malignant, benign, whatever, but we can be sure that there is a lesion here. So this is a concept of abbreviated breast MRI proposed by Professor Kuhn. And this is very promising. However, at the same time, we need to use the contrast agent to use this abbreviated breast MRI. So in the United States, in Europe, there are the guidelines for the high-risk women. Annually, breast MR or ultrasound is recommended. There are many, some kind of in detail, but would you like to have this annual breast MRI with cadmium contrast agent with 20s or 30 years old women? For me, if I am a woman with a high risk of breast cancer, personally, I would like not to have this contrast agent. So diffusion might play a role at the next stage. So okay, how to incorporate diffusion in breast MRI interpretation? So this is the textbook for the breast radiologist, which is called as BIRAT MRI. Okay. So BIRAT MRI, so this is a book. This is translated into many languages, not only English, Spanish, Russian, or maybe Thai language as well. We have a Japanese version of this book as well. So this BIRAT is issued by American College Society of Radiology. And this textbook, the pillars of the diagnosis is based on the contrast MRI, okay? So we have two pillars. First is morphology. So how the lesion is appreciated, the shape is oval, round, irregular, how about the margin is circumscribed, is clear or not clear, etc. And how the kinetics of the gut information. So homogeneous, heterogeneous, rim enhancement, etc. So based on these lexicons, breast radiologists make a report and make a category. And the other pillar is called as kinetics. So how the gut is washed in the lesion and washed out. So this is also applied in many organs, but breast radiologists respect this most. So if the lesion is malignant, we have a lot of that coming in the lesion, and it goes out very quickly. So first and washout is the most malignant findings in the breast diagnostics. Okay, so this is a two pillar, and we use that for almost all the breast cancers and women suspected of the breast cancer. So as we know already, contrast enhanced MRI has the best sensitivity compared to other modalities and diffusion as well. So contrast enhanced MRI has the highest sensitivity, almost perfect, for the detection of the breast cancer. So negative predictive value. Okay, so if this exam is negative, we are sure that this woman doesn't have a cancer. So negative predictive value is almost perfect, 99%. Okay, so that means, if there is some contrast uptake, we can be confident. Okay, there is a breast cancer somewhere, and if there is no contrast uptake, we can be pretty confident that there is at least no biological relevant breast cancer. And yes, and also higher cancer detection rates and lower interval cancers in intermediate risk screening is also emphasized in this contrast enhanced MRI. So with this data, lesion detection is very simple. So we can identify the lesion, but as a next step, for the characterization of the lesion. So this is the malignant, or how about the subtype or the breast lesion? Breast radiologists face many challenges so far. So based on the shape and morphology and the kinetics, we have the likelihood, the category, okay, category 4, 5, 6, we recommend the biopsy, okay, and category 3 to 1, okay, follow up or no further exam, etc. But this is mainly not on the decision tree strategy. So this kind of thing is not still kind of established in my understanding. So classification is really challenging. So as we have more breast MRI, that means we have more women with more recalls. So that is kind of the most challenging issue in breast MRI. So here I show you the two cases of the breast lesion. So one is malignant and the other is benign. Okay. So how about the diagnosis of breast cancer using diffusion? So please raise your hand if you can find something malignant or benign. So one is breast cancer and the other is not. Okay. So with diffusion it might be a bit challenging, right? So for me also it's very challenging. So and how about the qualitative diffusion? It's still challenging. So I show here the ADC map. What's the difference between the two? So this region might be a bit darker, and this region it looks very white, right? Yeah. So we don't measure the ADC map. This is an ADC map, okay? So we can measure the ADC map, ADC value on the ADC map. But just looking at these the maps, we can almost suspect which lesion is more malignant or benign. So this means that the left lesion shows more darker signal the value on the ADC map. So this lesion has an ADC of 0.9, and this lesion has ADC of around 1.5. Of course, it's better to measure the ADC value, but just looking at the ADC maps, it's very easy, I think, for the people to differentiate based on the dark or white or etc. So quantitative data already is very useful for the diagnosis of the breast cancer. Why is the difference of ADC values on ADC maps for the lesions? So this is well established by many people in many organs already. So ADC values reflect some kind of cellularity in the vision. Because breast cancer, in many cases, there are a lot of cells as shown here, so that means higher cellularity. So water molecules, as explained in the morning by Professor Suzuhan, with diffusion MRI, we can evaluate the extent of the water molecules. So in cancers, the water molecules cannot move as freely as benign lesions, because benign lesions, in many cases, they are sparse, lower cellularity density. So in breast cancers, very often we can appreciate the low ADC values from the ADC map, and benign lesion, we have higher ADC values. So this is an example. The upper case is malignant. In this is ductal carcinoma, and the lower case is benign fibroadenoma. Okay, so this is two kinds of diffusion and ADC maps. Only with diffusion and ADC, it might be we can make a diagnosis based only on diffusion and ADC maps. You see, for example, this lesion is very heterogeneous, and maybe the speculated we can say that compared to this lesion, right? So with the diffusion, maybe we can appreciate even morphology and shape of the lesion. Here's the malignant and benign. Okay, so this is the advantage of breast diffusion MRI. So compared to the contrast agent used images, diffusion is non-contrast. We can acquire diffusion with very short scanning time and good visibility, and we can evaluate ADC map. No need to measure ADC. Of course, it's better to measure, but we can already evaluate ADC map. On ADC map. And what the best compared to that is that we have a high specificity in distinguishing malignant from benign lesions. So here is diagnostic performance. This is the DCE. Sensitivity is perfect, 100%. On the other hand, diffusion is lower sensitivity compared to DCE, but please look at the specificity of diffusion. It's much higher than DCE. So diffusion as it stands, of course, DCE is a main technique, but diffusion is already the complement of DCE to include the specificity, right? And what's interesting here is that this is an NCCN guideline. It is the most important guideline for the cancer in the clinical settings. So it's from the state, and the society by the clinicians, physicists, surgeons, and the radiologists, etc., the medical oncologists. And what's interesting here is that there's a good news maybe for the community that they recommend the breast MRI, okay? They added the word here, breast MRI with and without contrast, only at the end of the last year. These 2 years, they recommend only breast MRI. So this with and without contrast appeared only the end of the last year. So that means that without contrast might mean something. It doesn't come from the radiologist. I assume that this word without contrast comes from some medical oncologist or surgeons, or at least it doesn't come from the radiologist. But at least there is demand. I assume that for the women, for the high-risk screening, some women might enjoy the scan. Not only with, but without non-contrast breast MRI screening. So this is the history of breast diffusion over 15 years. Consider the other organs as well. For instance, the brain has been very stable over the 10 years, but look at the breast cases around 2008. Do you want to see the images like this? When I was started the breast radiologist, I am a big fan of diffusion, but I was a bit reluctant to see these images, right? But just considering the over 50 years, the images got so beautiful and nice, and we can have, this is an example of a high resolution image of the breast cancer. We can appreciate the very small region just next to the main breast cancer. So only with diffusion we can appreciate now many information now. So here's an example again. So we have, as a radiologist, we have two different ways. One is qualitative and the other one is quantitative, right? And again, I would like to emphasize with the ADC map, it's better to evaluate, to measure the ADC value, but as it is already, we can differentiate these lesions. So here's an example of the prostate. So current status of ADC is already widely used. So the number of publications in terms of the ADC and diffusion MRI, as we can see here, about less than half of the other publications are breast, and which is more than the prostate. However, in the pilot, which is a textbook of the prostate for the radiologist, ADC map is already in there for years already. If you know that the finding ADC decreased or mercury decreased already in the strategy for the pilots. So pilots is following the pilots, and I'm happy that this year, in 10 years, the diffusion is finally in the pilots. So this is the correlation study of ADC value. Many papers have already shown that malignant lesion had lower ADC value compared to benign, but this is a validation of ADC. They divided into the data, the testing, and the validation data, and found that with ADC cutoff value around 1.5, they can avoid 16% of biopsies with unnecessary biopsies. So that means the lesion was suspicious at the beginning, they had a biopsy, but it's not malignant. So we can avoid as long as around 60% of unnecessary biopsy. So with my colleague, we have wrote editorial that's now the time to use this upper limb diffusion coefficient in breast MR diagnostics. So now the time is to come, hopefully. So this is a summary of ADC's threshold to differentiate malignant and benign breast lesions. There are hundreds of publications regarding the ADC values for the malignant and benign breast lesions. But because the acquisition protocols or the patients are very diverse, the reported ADC values are also diverse. But somewhat, we can summarize that the threshold to differentiate benign between malignant is around 1.3 or 1.2, 1.4. Okay, so this is the reported mean ADC value for the cancers, and this is the benign lesion and normal breast tissue. So for the differentiation between cancer and the benign, we can use the threshold around 1.3, 2, or 4, something like that. So this was also surveyed by the European Society of Breast Cancer Imaging, and many responded that 1.2, 1.3, 1.4 could be useful for the threshold. So regardless of the vendors and MRIs and the patients, we can use this kind of threshold as to differentiate between malignant and benign. So this is a recommendation from the European Society of Breast Imaging, which I have also involved in. We have years to complete and publish this result. So this is the minimum requirement. So to scan the diffusion, we need to consider all this information. So for instance, resolution could be around 2.2, the values 0 or 800. We need to spare for the cut separation, etc. And the other guideline is published also from Korean group, mainly for the cancer detection, etc. And they require also higher B values, 1,200. And a keyword from our senior for the quantitative biomarkers establishment. They also publish the information as a recommendation. So these all the techniques, the variants, but the recommended items are a bit similar between these communities. So the clinicians now really appreciate with the technologists and the physicists, we can refer this information and scan diffusion. In scanning diffusion, there are some issues to be considered. We need to check the B values, and we need to keep in mind that more higher B values, ADC values, generally become smaller, right? So, for instance, in Asian women, we have a lot of women with high density breast tissue. So we would like to scan more higher B values, for instance, 1,000 to 1,200 to 1,500, etc. But more higher B values, even in the same tissue, ADCs gets more lower due to this curvature at higher B values. Partially due to non-Gaussian diffusion effect and also the noise floor as well. So we need to, keep in mind the pros and cons, the optimal B values. So one optimal B value could be 800 in the breast, or maybe 1,000 or more if we can maintain a good SNR on diffusion. And with the Professor Bonizabia, we have also proposed the key B values which could maximize the diagnosis performance between the benign and malignant lesions at the key B values 200 and 1,500. So this could also be useful for the differentiation. So many guidelines have proposed some kind of different B values. So as a next step, we really need to think as a standardization, which could be the optimal. But this could be the power of the MR scanner, acquisition protocol, and also the women, or the density is different depending on the Asian women or American or European women, etc. So as a next step, I think we need to consider all the issues to be able to diffusion in really get into the clinical setting. So we will explain about beyond ADC. So there's a full potential of diffusion MRI. So in the clinics, if we can diffusion with 2B values, we can obtain the ADC, right? But not only ADC, with lower B values, there's a curvature from the straight line right down here. We can evaluate also the microcirculation, which is called as IVAN, intravenous incoherent motion, because the water molecules, the movement in the microvasculature is much higher, 10 times higher than the air diffusion. Okay? And higher B values, as I explained a little bit here, there is another curvature. This is mainly the effect from non-Gaussian diffusion. So many questions here, but is it okay as long as we can nicely evaluate, generate the values? So in a clinical setting, it is, the most easy way to estimate the value. So the kurtosis model is mostly used. So I've shown as kurtosis here, but we can evaluate the non-Gaussian diffusion effect as well. So this is the breast cancer, the upper one, and the lower is the benign lesion. And beyond the conventional contrast agent images, we can now appreciate various parametric maps, which is linked to the physiology and in vivo characteristic of the tissue. So now the time with the diffusion, we can have more information only with the clinical scanners. So here I briefly summarized the diffusion standpoint as a prognostic indicator for breast cancer. So this is the typing of the breast cancer, the hormone receptor, HER2, and Ki67. So medical oncologists define the treatment based on these information and subtypes. So ADC values, many papers have already shown that within the hormone receptor, estrogen, and progesterone receptor positive, ADC value decrease. This might due to the vascularity of the membrane permeability, but which is not validated yet. And with the HER2 positive tumors, we have more, higher ADC values in some papers, but this is not validated either. We speculate the blood flow or volume of extracellular volume might be contributed. And there are conflict results regarding Ki67, some positive, some negative, so we don't have a solid evidence here. But one thing interesting here that ADC maximum minus minimum kind of subtraction of ADC values might correlate with Ki67. So this is very interesting because this reflects the tumor proliferation in the cancer. So the ADC histogram might also correlate with Ki67. And regarding the subtype, there are a variety of the literatures which is mixed. So, so far in the clinical setting, we don't have no solid evidence in terms of the differentiation of subtypes of the breast cancer. So here we have tried to integrate multiple parametric maps into one kind of easy diagnosis because in the clinical setting we have a lot of images and maps and it's difficult to make a diagnosis. So one of the things is that diffusion diagnosis approach to mix all the information. We have found that it is comparable to BIVATS and SADC. I briefly explained before using 250, 100, a significant difference depending on the PGR status. And can diffusion predict the breast cancer prognosis? Breast cancer is the most common cancer in women worldwide, but we have relatively good prognosis compared to the prostate cancer, etc. But still, it is nice to if the imaging biomarkers can predict the breast cancer prognosis. So there are some publications for that. Mean ADC values itself does not predict the distant disease-free survival. On the other hand, higher mean ADC difference, which is the subtraction between ADC max and ADC minimum, is associated with poorer distant disease-free survival. And we have also shown here that the higher K, which is estimated with non-gastric diffusion than higher B values, is associated with poorer distant disease-free survival. So the patient with higher KD values is more likely to get metastasis with lower K value. So it is a lot of work to do all the time course for the breast cancer patients because with other more worse prognosis, many of the breast cancer patients live longer due to the development of the treatment, but some unfortunately have a not so good prognosis. So it is very good if the imaging biomarker, especially diffusion, can predict this prognosis. And diffusion time, as nicely covered already, diffusion time also makes a difference in breast cancer. So here is an example, okay, breast cancer. This is a T2 weightage and the contrast enhanced images, and this is the ADC maps, okay? So with different diffusion times, we can acquire the images even in a clinical setting right now. So this is an example of ADC map with short diffusion time, long diffusion time, and ADC change map between the short and long diffusion time. Okay, we can appreciate the central necrosis here, which is not contrast enhanced on the GAT. On the other hand, ADC change map shows no ADC difference between the diffusion times. On the other hand, peripheral lesions have remarkable ADC change with diffusion times, so which could add more information on the ADC maps. Because diffusion time is useful, we can now estimate the accurate diffusion distance of water molecules using the simple Einstein equation model. So compared to free diffusion in a tissue with hindered diffusion or restricted diffusion, we can accurately measure the extent of water molecules. So in this paper, we have shown that ADC change is associated with KIR67, which is a self-proliferation of the tumors in the breast cancer. And we have also shown here in the preclinical model that there was a positive correlation between ADC change and KIR67. So this is kind of the biomarker which could predict KIR67 or pathological biomarkers, etc. So this will be coming on. Here, I would like to show the work by Professor Dan Wood. She has nicely shown the climate